Good afternoon, everyone. I am Steve Owens, the Director of Health Equity for the Directors of Health Promotion and Education. We are going to get started. We have a panel, a very dynamic panel to discuss diversifying partnerships in order to achieve health equity. That's been a common theme of the past day and a half. How do we achieve health equity and also work on coalitions to address tobacco cessation, physical inactivity, ensuring that there are places where people can engage and have healthy nutrition options, and also combining those community clinical linkages. So we know that health inequities do not have a single cause, and all the public health work that we do cannot solely address such inequities. We know that it's going to take a variety of diverse partners, such as businesses, law, clinical, and also communications and education, to engage coalitions in order to address health equity. These multi-sectoral partnerships approaches through partnerships can collectively work to improve those underlying community conditions that make healthy living easier, particularly for those communities that we characterize as underserved or vulnerable populations. So how are we going to do this? You're going to hear from the experts today, people who have been working in these areas to diversify partnerships in order to achieve health equity. And today, we have a very dynamic panel. Our first panelist, I'm going to give a brief introduction because their more detailed bios are in the booklet. So our first presenter would be Ms. Jean Mahoney. She is the Senior Director for Providers Partnership at the American College of Obstetrics and Gynecology. All of those in the clinical arena, we know them at ACOG. And say, like, what ACOG stands for? So now you know. In this role, Ms. Mahoney directs alliances for innovations in maternal health and develop partnerships between ACOG members and partners on maternal and women's health-related issues such as tobacco control, alcohol and other substance abuse and use, behavioral health, and gestational diabetes, just to name a few. She's very busy, and I know it's very difficult working with doctors, members. But most important, Ms. Mahoney is going to share with us some of the successes that she have been able to do working with ACOG, and also she's going to share why ACOG believe that this particular project is very important. And then we're going to transition right over to another physician, Dr. Deanna Worthington. She is the Executive Dean at the Petrock College of Health Sciences at Bethune-Cookman University. Dr. Worthington is a fellow of the American Academy of Family Physicians. She previously served as the Associate Dean for Academics at the University of South Florida. And also, while she was at the University of South Florida, she was over student affairs and director of the Office of Minority Health at the Florida Department of Health. Dr. Worthington will share information about the importance of including educational organizations and institutions and community health efforts, such as helping coalitions deal with low literacy levels. Also, she will share how minority-serving institutions, for those of you who do not know what minority-serving institutions are of higher education, they are historical Black colleges and universities, Hispanic-serving institutions, and tribal colleges and universities. She will share how it's very important to engage those institutions in coalitions and partnerships. And then we will hear from another expert with a Florida connection, Ms. Tameta Cozart, who I'm very fortunate to have on staff at DHPE. She is our communication manager for DHPE. She has over 10 years of public health experience and 15 years of experience in public relations and health communications. Prior to stealing her, prior to coming to DHPE, Ms. Cozart served as the Deputy Press Secretary for the Florida Department of Health, as well as the Marketing Coordinator and Public Relations Manager for the Health Department Women's Health Program in the Office of Minority Health. Ms. Cozart will discuss how to engage media professionals in your coalition, how to get the word out. That's what she's going to share with us in a very professional way. And so when the camera comes, you know what to say. Right?
No.
So what? Oh, I'm both. Okay.
That's the spokesperson.
Oh, that's right. That's right. Okay, and then finally, the one who's going to bring it all together related to social justice, we have Susan Kindig, who is also an attorney and a women's health nurse practitioner with over 30 years of experience in healthcare. As the president of the Health Policy Advantage, Ms. Kindig provides policy analysis, consultation, and strategic development support for healthcare providers and community organizations responding to the rapidly changing healthcare environment. She is a gubernatorial appointee to the Missouri Task Force of Prematurity and Infant Mortality. Ms. Kindig will provide insight on engaging the legal community and coalitions. So this is a test for the panel. Who goes first? Ms. Mahoney, thank you. Let's give our panel a hand.
Thanks, Dr. Owens, and thank you for just listening to a little bit of what I have to say. This is a really esteemed panel, and I feel like the junior member here, but I'm going to do my best. So I want to talk a little bit about engaging and understanding the provider's role in the coalitions. So here we're going to look at medical homes for women being really an important thing, engaging healthcare providers, and effective provider engagement and integration. So what's a medical home? Anybody here know what a medical home is? Oh, okay. So it's a place or a person where they know you. It's like the Cheers of medicine. It's a place where they know, where your medical history is kept, your records are kept, you get routine checkups, medications are reviewed, health behaviors are explored, and health planning is discussed. It is one of President Obama's initiatives to engage people into medical homes, because it's where your medical work should be done and cared for. They're the place where you can go and get your needs met by somebody who understands and knows you and your culture. And this place has to be accessible and a place where non-threatening medical care is getting done. So why is that important? I think I just mentioned that. During the next year, there's one question that needs to be asked of every woman who goes into their physician, and that is, this next year, do you plan on becoming pregnant? A woman of childbearing age should be asked that question every year. And if they're not, well, first of all, if they are, that means a whole different manner of where the provider needs to go from there. So they can, at that point, if she says yes, they can screen for chronic disease and STDs, discuss health behaviors, and assure that your immunizations are up to date. There's a long list, but those are three important ones. If you have no, you then discuss effective contraception, and then provides routine screening, immunizations, and behavioral health screenings in a different manner. When the person is planning on being pregnant, you're really looking at how you can do preconception care for her pregnancy. Okay, so our program, the Community Partnerships, the WIC program, it helps to identify medical homes for women. And that's why it's a wonderful and important way to get things started. It connects postpartum women back into primary care, and it improves the connection to healthy foods. So these are really activities that help reduce chronic disease. The importance then of that postpartum visit. So pregnancy is really the window of future health for women. And what I mean by that is that things that happen during pregnancy, high blood pressure, diabetes, these may go away or become reduced after the baby's born, but they're the window for what's going to happen in the future. And so the most important thing for a woman who has had some kind of problem during her pregnancy is to get that next visit, that postpartum visit, where she can then be hooked up with primary care physicians, get into a medical home. Because without that, in 5 years, it's likely that she has type 2 diabetes and moving forward. It's very likely that her high blood pressure will continue, and we find that women, even young women, are starting to have heart attacks in very early, in their 40s and 50s after having these events during their pregnancy. So it is the window. Also looking at weight gain. And these, as I say, these can really be modified. So the other thing that postpartum visit does is really provide the postpartum contraception and birth spacing information that's needed. And these are really important if there's been a poor pregnancy outcome. So really consider thinking about, that woman who had a stillbirth or premature baby, a low birth weight baby, a baby that needed neonatal care. That's a woman that really needs to get into that postpartum care immediately. And if the mother had severe mood disorders or tobacco, alcohol, drug abuse, also the same kind of thing. She really needs to get into care. And that appointment at the WIC or appointment within your coalition can drive her back in. So we basically talked about that postpartum visit as being really important. This is what that postpartum visit addresses, which is weight, nutrition, blood pressure, breast exams, review of immunization, and make sure that her immunizations are up to date, her psychosocial issues, and provides counseling for those other things. But we find that at least a third of the women who receive Medicaid never go back to their postpartum care visit. And really because they have negative feelings, they don't like checkups, they don't want the long office waits. And so it's really up to us and coalitions to get her back in to care. For the service provider, their role is to just keep women engaged in their health care and to build on the partnerships. And so the difficulty is sometimes engaging that service provider. And one of the real things that we find on and on is that the provider doesn't understand what WIC does or the coalitions do, and the coalitions don't really understand the provider. And really, if you're going to be engaging a provider, just be very distinct on what their role is in the community and continue on with it. And that's pretty much the end. Yes. Thank you.
Thank you so much, Jeannie. So back in the day when I wanted to become a doctor and was going to medical school, the medical home was your family medicine doctor's office, so it used to be my office. So I'm here to just talk about diversifying partnerships around the educational arena and specifically touching on minority-serving institutions. So let's just hop right to it. So bringing us all back to from whence we've come, and that's the social determinants of health. Taken us many years to kind of figure out that these are the pieces that go into that. And on the other side, you see the county health rankings depiction of what percentage those things bring to how healthy we are. And I think it's not a bad thing. So you'll see some asterisks on my side of it, your neighborhood, your ethnicity, who your parents are, and that's because those are some of the things that my college decided to touch on. We have, our college has 3 foci, health equity, healthy aging, and health advocacy and policy. And so we've decided, we are a new baby college. We're about 2 years old, even though the university is 112 years old. So we really needed to think about how we wanted to engage with the community. So as we step back to look at that, our potential partners come from all of these areas, healthcare entities, the Department of Health, the Florida Department of Health, community service organizations, some national organizations, places of worship, around Bethune-Cookman University, which when you're speaking about the determinants of health, actually that land was given to Mary McLeod Bethune, but it was actually previously the city dump. So we actually sit on, a site, a remediated site. But having said that, there are 23 churches within a 2-mile radius. So the rest of the list you can see, we all work with them, but for us, those are the folks that we were looking at within our area. And so let's look at what that looks like in real time for the Petrock College of Health Sciences. I'll just choose a few from each of those. Under healthcare, one of the first things that we did was we brought Volusia Volunteers in Medicine. Volunteers in Medicine is a national organization providing free medical care to the working uninsured. There was such a group in Daytona, however, it had no home, it didn't live anywhere, it wasn't actually seeing patients. Well, I have a Center for Health Equity as part of my college, a physical building that was designed as a clinic, and so that's where they live now, and they are, they've just recently seen their 300th patient, so we're moving and shaking. The Federally Qualified Health Center Initiative, again, where we are in Volusia County, in Daytona Beach, there's a large hole. There are no federally qualified health centers within the area. And so we've pulled together as a coalition with the 2 main area hospitals, the main mental health service provider, which is Stuart Marchman Act, the Florida Department of Health, and another FQHC from north of us to bring those services there. And we're so glad that President Obama dropped the NAP last week. We are very excited. Let me move on to DOH. We do everything we can with DOH. Right now we're involved, my Master of Public Health students are involved in doing a policy scan of Daytona Beach along with the Department of Health and a few other community service organizations, because we see that some of the policies are actually blocking and contributing to those poor health outcomes and determinants of health. We had a Men's Health Summit that was actually just this past Saturday, the first one ever in that area, believe it or not, with 23 churches. We had 200 men, ages 25 and older at that summit, really an opportunity to make an impact. Also partnered with Halifax Health on that, which is another entity. So because of the healthy aging piece, we've engaged with playwright Garrett Davis, who has the official AARP-sponsored plays around Alzheimer's disease, Mama's Girls and Forget Me Not. And so he comes on an annual basis. This will be his 2nd year with us. He'll be in here in just 2 weeks and providing education to the community. And then in addition to that, we also have a caregiver support group. We also have 2 lawyers who help us assist families with planning for end of life, et cetera, et cetera. So it's sort of again, this multi-effort. Actually, and in following with what Jean said, we actually have also partnered now with the Florida Department of Children and Families and the local and national Healthy Start to become a family place where that window of opportunity does not go unused. And so young mothers, young families can access the state services right on ground at the college within their community. And so we're very pleased to be a part of that. In addition, we belong to a number of multi-partner collaborations across Daytona, One Voice for Volusia, Community Health Needs Assessment, which we all need to do to maintain compliance with ACA, and the Midtown Health Equity Coalition, where we are engaged in walkability, audit studies, and food security issues and community safety. So the lessons learned for us, we want you to know, is that we want to partner with you. and we can step outside of the box together. I mean, we can do things in the box, but let's see what we can do together outside of the box. Core functions of public health still work for what we're doing. It's just important to think about how you want to cultivate partners and make sure they align with your mission. And that, we have different thoughts about how we get to a certain point. Those of us in the coalition around the federally qualified health center, some of us kind of want it for a different reason than others, but that's okay. Whatever way we get it done, we'll be very pleased about it. So let me just say this. To engage with us or to work with us really helps you, I think, in terms of being available to partner with you on grant writing services, writing and publishing the results of what your coalition is doing. We have students galore to serve as volunteers and interns, and in many cases, if they're in master's or doctoral programs, they also bring a level of work experience. You know this. It gives you media exposure to be connected with us, venue and space, and then particularly if you're working with the HBCUs, Hispanic serving institutions, or tribal colleges and universities, we often have a strong, meaningful, and historic tie to the community, such as Bethune-Cookman does. I can guarantee you that all of the HBCUs have that. We bring a level of expertise and understanding about health equity, about the health disparity issues, about social determinants of health, because we're not just working it, we live it every day. As you know from the studies, it doesn't matter what our socioeconomic status is. I still was just followed around the store the other day. And we have a demonstrated commitment to the amelioration of poor health outcomes. And so we think it would be wonderful to continue to work with you on any coalitions. Just think of us when you think of building that team. Thank you so very much.
Okay. And one of the reasons, Dr. Owens didn't mention this, but one of the reasons why we are going through our slides pretty quickly is because we really want to make sure that we have enough time for you all to ask us questions. So that's why we're just giving you very small and brief snippets. And then we definitely want to have a robust conversation. So I am Tometta Cozart. I'm going to talk to you all about the aspect of media engagement. Okay. So this is the disclaimer that I'm sure that you all have seen all day. I do not work for CDC, so nothing that I am going to say or express is directly from them, and we just want to make sure we put that out there. Okay, so policy systems and environmental change approaches. The aspect of promoting these particular approaches is part of your coalition. It's one of the reasons why we are doing this work, because we want to make sure that we're getting the message out about the aspect of the fact of not really looking at individuals anymore, but the aspect of looking at population health, and that systems have to change. We have to actually promote systematic changes to be able to address health disparities. However, that's hard to even explain to people who work in public health every day. So to explain that to the general public and to talk to new partners for them to be able to come on board is one of the reasons why we want to make sure that communications is something that you all are looking at from the very beginning of your particular projects. Okay, so I work for the Directors of Health Promotion and Education. We are a Category B organization. So one of the reasons why we are a part of this particular project is to support the work that you all are doing, to provide you with technical assistance and communication needs. So some of the tools that we have created are listed here on the slide. If you go into Studio 9, after this session, that's where the spokesperson training is, and you see these packets left over. I do invite you to take one. These are the approved templates that we created for the coalitions to be able to use. However, you picking up this particular packet gives you these resources, and they're also available on the online resource directory that we've created for you. But if you do not have the capacity within your coalition to use these, then this is not going to help you. So this is one of the reasons why we are talking about the aspect of why you should engage individuals who actually can help you with your communication efforts for your coalition, and to make them a part of your coalition from the very beginning as a member, and not just when you need to try to get out your success stories, okay? So some of the other resources that I want to touch upon quickly is that for APA, they actually did create a planner's communication guide, and although this is really created from the aspect of APA for planners to really talk about the communication of the intersection between health and planning, it really does help across the board in terms of all coalitions to be able to talk about PSE approaches. Another particular resource are organizations that I do think you should look for local chapters in your communities in terms of the aspect of trying to find individuals who do work in media and do media relations every day. So the Society of Professional Journalists, the National Association of Black and Hispanic Journalists, Public Relations Society of America. Please look at your local schools of journalism in terms of students, as Dr. Wathington has already mentioned, and then online bloggers are also good resources too to have as a part of your coalition. So one particular organization I'm just going to talk a little bit more today about is an organization that I am a member of, and so that is the National Public Health Information Coalition. Okay, so one of the reasons why I do think you should engage individuals that are a part of this particular coalition is because these are individuals who work every day as public information officers for health agencies. So either at the state health office or at the local county health department or some other health agency. So they are health communicators professionally. They are invested in the work that you're doing, and so it's not like you would have to sell them in terms of the aspect of your mission. You already have a shared vision, and they come with a skill set with the aspect of media. Okay, so this is the largest organization of professionally trained public health communicators. In terms of the aspect of their organization, they have a structure that's very similar to HHS, the U.S. Department of Health and Human Services. They are broken up into the same regional aspect. There is at least one member in every state, and there's usually at least 25 in most states, but there's at least one in every state. Okay, so in terms of the aspect of the unique characteristics, like I said before, I've kind of gone over this, most of them already work as public information officers in a health section. So speaking about the aspect of health, speaking about how do we reduce chronic disease, utilizing PSE approaches, those are things that they're already trained to do. So you would just need to talk to them about the aspect of the specific interventions that you are doing at the community level. And again, although these individuals work every day in terms of the aspect of health communications, they still live and work in your community. So investing in the aspect of the work that you're doing is not something that you would have to be able to sell them on. This particular organization also has a vast resource in terms of online libraries. So the aspect of chronic disease and health promotion, these are resources that are already available to you. So I know in terms of the aspect of cohort 2, some of you all are literally just getting started. So if you're looking for resources that you can use online in terms of the aspect of social media promotion, or if you are looking for something that you can add to press releases, that you can add to the aspect of video release, then these are resources that have already been vetted, they've already been created, and so you will be able to use this. So this gives you another outlet for information. The other thing about making sure that you stay connected to these particular individuals is because of the fact that they are connected nationally to this organization, which is nationally connected to CDC on the aspect of communications. So they have regular monthly calls with CDC. So the latest information that's coming out about health communications is coming to these individuals. So they actually would be a resource and an invested interest in terms of the aspect of the work that you all are trying to do. Okay, so just to wrap up, last but not least, why would you actually want to engage media professionals in your coalition? Again, I am not speaking of when it's time for you to do your success stories and you're trying to disseminate the work that you're doing. I am talking about inviting these individuals to come to your meetings, to be on your committees, to serve in the work that you're doing. First and foremost is because you have deliverables around communications, and I know you need assistance doing that. So you have a communications plan, you have to get media impressions. Why not ask people who are already helping you to do that work? Because then it's not an ask, it's just the aspect of the fact of something that they're doing anyway. You need help with crafting messages for your coalition to prevent chronic disease. You definitely need to make sure you're promoting PSE approaches. And then also you do need to make sure that you are looking at sustainability of your coalition. So for no other reason, these individuals can help you to promote your coalition so that you can continue to be able to sustain your efforts after this funding runs out. All right, thank you.
Thank you. And while is somebody switching the slides? Okay. While we wait for the slides, what I'm going to do right now is I want to take the opportunity to talk about reframing the conversation. What wasn't said in my introduction is I'm an old public health nurse. I've done home visits. I have birthed coalitions. I have worked with coalitions all of my life. And I think we need to start reframing the coalitions, reframing the messaging about coalitions, because everything you heard of up until now, the medical homes, the academic partnerships, and so forth, cannot succeed unless they have that community voice wrapped in. So I'm going to talk with you about how to make that win-win happen. I come from St. Louis, and what you see up here, you can't really see this really well, but St. Louis is the sixth most segregated city of its size in the country. So we know all about health equities. That demarcation that you see between the red and the blue is the inner city, where there is the economic situation is certainly much worse than it is in the county. We have a lot of health disparities. They tend to be worse in that area and so forth. What is really interesting is that many of the people that work with disparities and inequities, and it's hard to deal with health inequities when you have systemic inequities elsewhere. So one of the things I would invite you to consider, and I can talk more about some of the social determinants activities that our coalitions do to engage partners during the Q&A, but remember, sometimes the people that you are approaching may work with your population. They might not know the reality of your population, so it's our job to help them understand the reality of our population. I'm going to go through a couple of cases that can show you the wins. In this case, this is the woman you all know, got pregnant in high school, delivered a preterm baby, no prenatal care. Her second pregnancy, she was homeless because someone was killed in her home. It became a crime scene. She couldn't live there. She was living in a car. She delivered another preterm. Her third pregnancy, which came on the heels of the second pregnancy, ended up with a preterm too. She did have prenatal care this time, but she did not feel supported. She was diagnosed with a mental illness. Well, turns out she was still traumatized from the relative being killed in the home during the second pregnancy, and she had a provider who did not understand trauma-informed care. Her fourth pregnancy, she finally found the Healthy Start program. She delivered a healthy full-term baby, stayed in the Healthy Start program, became a mentor to other pregnant women. Success story, right? Well, not really. The vulnerability continues. She is in and out of homelessness. She had an incident in 2012 while the ceiling in her apartment fell on her daughter. She pushed the landlord. I probably would too. She got evicted and charged with assault. As soon as a volunteer legal group got into that scenario, the charges were dropped. The bottom line is legal issues such as outstanding warrants for arrest due to traffic stops, credit judgments due to breach of contract, many times with predatory lending and other predatory businesses, place people at a disadvantage that ultimately places barriers to their health. Another case, this was a 50-year-old legal immigrant, Medicaid recipient due to a disability. She lost her coverage. She had multiple psychiatric diagnoses. She was combative, disruptive behavior, delusional. This woman, I was at this time doing some pro bono work right after law school, helping to, in the special benefits division as a volunteer attorney, helping to get people their coverage back. Basically, I was learning. And we went into her home. And the bottom line was, because I'm an old public health nurse and I started hearing the story, I asked to see her medications. She had 5 different variations of narcotic-containing medications. Her family was trying to give her all of these medications along with her psych medications because they didn't know what anything was for. The bottom line was this woman had emigrated here from a war-torn country. She had PTSD. She wasn't delusional. She was having flashbacks, and she was having drug interactions with all of her different medications. Lawyers need healthcare providers to help them understand this. They need community coalitions to help connect them with resources. And this one, was a young man. I was helping with a program with a local AIDS project where we were providing, we were helping people who were in the terminal stages of their illness develop wills. And this man came in, and he was in a rush to get a will done. So I hurried up and did his will, except he looked really healthy. And so finally, when that was all done, I said to him, so tell me how you were diagnosed and where you are in your progress, how you doing? He said, oh, I'm not sick. This is the only way I could get a will. I have a son. I have a little bit of money in the bank. I have a 2-year-old. I'm going to get killed. And when I get killed, I want him to have the money. How are you going to get killed? He told me where he lived, and he said, people get killed every day in my neighborhood. I know my time's limited. So then I had to talk to him about how being knifed, beaten, or shot may not kill you, and we need to think about a healthcare power of attorney. And after that, I told him I was a nurse, because usually I didn't tell them. And then I said, tell me why you stay. Turns out he couldn't finish school. He had been in one of the schools that have the predatory student loan programs, couldn't pay his loans, couldn't go back to school, couldn't go to a reputable college. Lawyers need help connecting people to community resources that can help them while they untangle the legal issues. So the last thing I want to say, it breaks my heart when I hear coalitions and grantees talk about how we have short-term money. We got to figure out how to be sustainable. Right now, the health care programs that are in place, the medical homes and so forth, all rely on quality and cost metrics for people to get paid and be successful. I would argue that they cannot be successful without taking advantage of those community agencies that are already there, that know their community, that can leverage the existing services to help improve those outcomes. And in that way, we need to think about reframing that conversation so that we can leverage all of the resources available in communities rather than creating new ones to create sustainable funding streams with those payment models. And I'll leave you with that thought. Thank you.
Thank you all for those presentations about how we can diversify and engage partners into our coalitions. At this time, I have a couple of questions for the panelists, but I also invite the audience to ask questions about how to engage and diversify the partnerships in your coalitions. For the first question I would like to ask Ms. Mahoney is, you work with physicians, healthcare providers through ACOG, and my question is, well, how do you actually get physicians to get involved in a local coalition and really contribute to the coalition, just besides just being, I'm a member and just showing up, what are some of those strategies to get healthcare providers involved?
Is this on?
Yes.
It's enough. Okay, great. So it depends on the provider. It depends on the coalition. There is no one straight answer. One of we have a provider in the audience now. Her patient asked her to be part of the coalition. Isn't that right, Dr. Thompson? That's right. So that's one way, is to really have the patients that are part of coalitions, or the people that are part of coalitions, talk to their provider groups about that. We actually at ACOG are working to make working in a coalition be part of a program to help continue their board certification. And that can be very important. We're working now on the program, and we'll get that back out to you so that others can understand how that works. But all physician groups need some kind of recertification for their board board membership. And so the way to do that is to participate in some educational or really practice change process. And this, obviously, being involved in a community coalition is not just a practice change process, it's a life change process. It's a wonderful opportunity for physicians to have to really see where they can be effective. And so we're really working to push them into that.
Thank you. Another question that I would like to ask Dr. Worthington. You mentioned that you have access to students. You're at a university, and oftentimes the students need projects, as per se, to meet their academic requirements. What advice will you provide to the members here that need to develop coalitions? How could they connect with the university? Is there a particular school within the university or a program? Well, what would be the connection? How do they approach you at a university?
Well, so I think that it depends on what your coalition is focusing on and what your local university has. So I've been at some rather large universities that have, schools of nursing, schools of pharmacy, schools of public health, schools. It's very, it's very kind of siloed. But I think that understanding that approaching the schools based on what your priorities are is the first piece, and it's usually easier to go through. They will usually have a person who is in charge of internships, practica, special projects. That's the person you need to connect with. It will be on their website. Often people come through me at my particular school, but that's because we're a very small university and my college contains all of the health sciences, right? So, and because I'm readily available and seen in the community for them to speak with me. But I think the easiest way to get in the door is to go through the internship, the practicum coordinator. If by any chance in your community or in your coalition and in your work, you're working with the chairs of any specific departments, you can also utilize those folks as well. And many of you probably already know that, but that's the easiest way.
Okay. Well, to the entire panel, I would just like to thank you to ask, do you mentioned to Meta specific organizations, but do other panelists can recommend any tools or organizations that are available to local coalitions to increase their knowledge of health equity and social determinants of health, and how can they connect to those coalitions locally?
I think that's a really important point in leveraging. So what I would suggest, and probably y'all know this, if there are WIC coalitions, then certainly looking at the larger maternal, child, and family health coalitions that are available in your communities. Oftentimes the United Way has collective impact efforts that are looking at lifespan approaches. So sometimes the sustainability and the success of the effort is aligning with what those other efforts that look like yours are doing. In terms of legal services and social justice services, I would really encourage you to think about things like your local legal aid, whatever your legal aid services, because oftentimes that's going to be your first go-to for some of the problems that I had talked about. Medical legal partnerships. How many of you have ever heard of medical legal partnerships? Mm-hmm. Okay, one person has. That's a wonderful opportunity where legal services partner with a healthcare system, healthcare entity, so that, for example, if you are going out and you're dealing with a child with asthma and you can't get the landlord to fix the place and you can't get them out of there without severe penalties, you have that next level, you have some legal services available. And I've seen medical legal partnerships for all kinds of different things in the healthcare arena, breast cancer, chronic diseases, and so forth. So I would encourage you to look at the literature along those lines, because that can also be helpful. Similar to ACOG, many law firms require their lawyers to do pro bono work in the community. So sometimes simply talking with the bar association or, making friends with somebody at one of those firms can actually get you someone on your board or working with the coalition who turns out to be very passionate about it?
I did mention the National Public Health Information Coalition, but I also want to talk about the aspect of when I worked at a state health agency. So when I worked for the Florida Department of Health, I worked in the Women's Health Program and I worked in the Office of Minority Health, and that work was greatly rewarded. But that also comes with a lot of barriers in terms of the aspect of what you can do if you are not in legislative affairs of the aspect of your state health agency. The work I was able to do on the community level with coalitions and with community health initiatives, it allowed me to be able to do a lot more in terms of the practice of the work that I did every day at the state level. So I would say look at your state offices of minority health, look at your state health agencies to see if they have an Office of Health Equity. And the individuals that work in those particular offices would probably love to be able to do work with you at the local level because it gives them more freedom to be able to do the work that they advocate for every day but are not able to actually do in practice. So having said that, the National Association of State Offices of Minority Health will give you a list of all of the offices of minority health and health equity around the country and in the U.S. territories. That's a great place to start, again, to engage people who are doing health equity work every day.
Yes.
I was very interested to hear about the men's program, men's health program through the churches. I just love to hear a little more about that and how you were able to engage men and how did it happen in the churches, how did it get
Sorry, just so that I can see you while I don't want to speak and not see you. So that actually came about from a coalition of, actually, Bethune-Cookman, again, being the center of that. And then we brought in two of the major health systems there in Daytona, actually, the hospital systems, and formed a clergy council. And so we've been meeting with that clergy council now, along with the mental health service provider for a little over a year and a half. And really, I'm going to tell you, it was the ministers that were key in bringing the men there. You know, certainly it's easy for us to provide the information for them, the interactive sessions. We had full screening for them and connection to primary care, a primary care home if they did not have that all in that event. And we're now discussing whether we need to have that twice a year as opposed to just once. So that's what it was really born out of. Does that answer your question, or? Okay, you're welcome.
Yes.
Out of our coalition laser that we saw, we were looking at the one question campaign, but scrapped it because we felt that we didn't have the data to justify the link to chronic disease. So if you could speak a little on that.
The data about chronic disease as,
The link between unplanned pregnancies and chronic disease.
oh, but there's plenty of it. Would you like me to send you some information? Sure. It's really that, what I just said, it may not be exactly unplanned pregnancies and chronic disease, but it's things that happen during a pregnancy that later on, as I say, pregnancy is the window for your future. And so things, at that point in time, a lot of your systems aren't operating exactly in the same way, and particularly your immune system is not functional as much, because otherwise you would reject the baby. So at that point in time, many things can happen that wouldn't normally happen for a woman who is 23, 24, the high blood pressure, the diabetes. But this is what we see. We see them 5 years later, and that's where we really see the issues come up. There is a way, when we're looking at that period after postpartum and within 5 years, if we can really treat the issues while they're happening, then the chronic disease doesn't happen quite so intensely. I can't say that it totally wipes out the fact, but the intensity of it and the treatment of it become a lot more reasonable. The same with substance abuse. So if we can really look at substance abuse problems postpartum and begin to treat them well, then again, there's a chronic disease that doesn't happen. Smoking is the same way. Many women stop smoking during their pregnancy or cut down tremendously, but as soon as that baby is born, they're ready to have that next cigarette or vape or do one of those. And so being able to look at postpartum smoking cessation and keeping that going is a great way to stop that chronic disease from happening. So it's really about looking at behaviors that behaviors and conditions that get exacerbated. Either they reduce during pregnancy or they're increased during pregnancy, and we need in that postpartum period to do something so that they don't continue. Does that make sense? Yeah, so that one question is a really important question.
Sorry, so I just wanted to say something about sustainability. Much like Ms. Kendig, I'm a public health practitioner, have been for about 32 years. And so that comes first. And the community that I entered into 2 years ago in Daytona Beach is not, that university is not laden with grants and, you know, they don't have NIH and SAMHSA. I mean, they do now, but they didn't then. But the majority of what you saw on the screen that we are trying to accomplish, none of that is grant funded. That is just the partners coming together, including One Voice for Fallujah, which actually contains businesses from the community as well as community organizations and healthcare organizations. And we are coming out of our own pockets, but we're getting the work done. So I think that speaks to the potential for sustainability. Once you get all of the partners involved, even when your monies are gone, when everyone's committed, then people will stay there and continue to work. So I just wanted to make a note about that.
Okay, thank you. Ms. Kendig, one of the slides that I think it was your first slide, one of your slides, it was of St. Louis, there was a demarcation, you know, the red and the darker colored area of the map. And so my question to you would, well, how can health coalitions incorporate those social justice issues into those community projects that they're developing these coalitions around? So, you know, you've got a population of the city that you're trying to provide the services and improve health. So how do you incorporate those social justice issues?
Well, I think number one is actually being aware that they are there. And one of the things I'd invite you all to do, because I don't know that you caught this on the slide, if you Google "For the Sake of All," there is a website by a researcher at Washington University is actually doing some phenomenal work looking at that very issue. What are the non-medical drivers of health outcomes? So the first step, I think, is really understanding what our communities and what our families are facing that is placing barriers to that. I think the second thing that is really important, and I've heard this in some of the sessions that I've been in, are the collective impact efforts. Bringing together, again, the non-traditional providers, the usual, you know, we like to get the usual suspects together. So if we're addressing health, we look at healthcare and so forth. But in collective impact efforts, we're really broadening that to, number one, help our communities understand what are those social determinants, and number two, what their place is in bringing their resources to bear, both intellectual human resources as well as possibly financial resources, to help address these issues. I also think part of that is really stepping back and understanding the systemic drivers, not necessarily of what's happening today, but how over decades we have created issues that are impacting social determinants. Because once we truly understand that, we can then be able to begin chipping away at them. So I think it's number one, understanding the systemic underpinnings that are driving the social determinants, understanding how those social determinants impact the health outcomes, and developing those common agendas that bring together the not-so-usual partners.
Yes. Please state what state you're from.
I'm from Oklahoma.
Okay.
Tulsa. Dr. Owens, I'm so glad that you actually brought that up because it's kind of the question that I really wanted to pose to you all, and I'll open it up to any of the panelists. But in my community in Tulsa, it's a very segregated community, racially and ethnically. But that's been a very historical, it's changing a lot. We're seeing a lot of our population shift and move. We have a lot more diversity in our city than we have before, where it was a lot more segregated. But there's sort of this, we all remember when it was so segregated. And so whenever we talk about some of our coalitions coming together and getting the right people to the table, non-traditional partners, we went across those racial and ethnic boundaries, that have been built up before we went
Right.
down those walls. But then this question of positionality comes up, and so we really struggle on, do we really try to encourage positionality and have folks from those historical areas represent, their background, or do we try to, in the spirit of health equity, really show how we have those population shifts happening and position ourselves in that way? We're struggling with that.
So in Daytona, we've taken the tact of, because we have much the same, we still have a community that is quite segregated, and that's the community where the university sits. There was much resistance when I first arrived there to partnering with the major safety net provider, because for a very long time, and well into this century, they didn't accept anybody from that community into their hospital, or would not treat anybody there, even though they're right on the border of that community. So hence, all of the thought leaders in that community are like, we're not dealing with them. What we did, we started with some basic focus groups and community sessions for the clergy, for the city commissioners, just around social determinants. Let's all get on the same page about what this is and what's happening. Even though you live in it, you're not really getting it. And then we gave Halifax the chance to do some things within the community that they funded, but kind of hands off. Like, we're here, but we're not here. We're non-threatening. We are open. And they were also able to share some information with the community about the amount of uncompensated care and care they are providing for that population through their ED, et cetera. The next step was to invite Dr. Otto L.A. Troutman. Sorry, that was just, we just had a chance to do that. And so he actually spent 2 days with us, engaged in a social justice initiative, taking the city commissioners, the mayor, the clergy leaders, and the other thought leaders around the city to really look at, it actually was the beginning of our policy scan that I was speaking about earlier, so that we could look together and discuss it together on the bus. And it was a very vigorous discussion, but we needed to have that. So then once we move past that point, now we're at this point where we're doing things like, the Men's Health Summit, the Baby and Me, where we're trying to focus on moms, the partnership with DCF. And the community has really opened themselves to this, but it took a minute. So.
And I'm going to build on that. I'm so glad you brought up the community discussions, because the second slide that I showed was exactly that. It's a little bit different in that ours is an ongoing event, if you will. Our local Maternal, Child, and Family Health Coalition actually developed what I call a social determinants activity. It's essentially similar. It is a tour, but it's done in very small groups. And they did it initially, about 12 years ago, to orient their board members. Mm-hmm. But it starts out, and it starts out in our zip codes that have the highest infant mortality, because it sort of grew out of the Healthy Start program. And what they do is they start at the Homer G. Phillips Hospital, which was the historic Black hospital in our area. In fact, it was apparently famous across the country. That was where many African-American physicians and nurses were trained. They had wonderful outcomes. I was fortunate when I moved to St. Louis. I got to work with some of them best public health nurses I've ever met. That being said, she starts talking about, as we go through the neighborhoods, the deterioration of the neighborhoods once that hospital closed, due to, obviously, the physicians and the nurses and so forth that lived in the neighborhood moved out. Going through neighborhoods where land was given to residents who could move out and build if they had the opportunity, except when you look at these houses, they're cracked down the middle because it was on the city dump, and the dump is sinking, and there's also a cancer cluster there. Moving into the areas of the county where business has pulled out, there's no daycare, there's no grocery stores, there's no transportation and so forth. And you begin to see how over a period of 30 years, there has been this systematic dismantling of a community. That experience is a game changer. The coalition takes policymakers on that tour, has the same discussions. The other thing I didn't tell you is my day job is I coordinate a women's health nurse practitioner program at University of Missouri St. Louis. My students have been going on that. They have had that experience integrated into their education for probably, well, since the inception of the tour, however long that's been. And consistently, when I ask them before graduation, tell me what has influenced your work, what you want your women's health nurse practitioner practice to look like, they say, that was a game changer, because up until that point, even though I worked in fill in the blank, high risk setting, FQHC, whatever, I never understood where my patients came from and where they were going. It is such a powerful tool, and if you're ever in St. Louis, call me and I will make sure that you get to see it.
Yeah. So in terms of the aspect of piggybacking off of both of those things, I've participated in similar activities. We call them windshield tours, and we've connected them with the aspect of many opportunities for us to work with the community and to bring them together. One of the things I wanted to bring up in terms of the aspect of what's a great opportunity for a lot of your coalitions, especially if you are a part of APA, is that you can do the same thing and do it from a history of planning. This is an opportunity for you to really be able to educate your community about the history of your community, of how did it get to be the way that it is. It wasn't segregated by the aspect of it just happened to be that way. Things happened. There were red line zonings. Things occurred. And so you guys, in terms of APA, you're the experts in the room to be able to talk about that from a planning perspective, and then to open the door for the changes that can be made and how they can join in that work. Now, what that does is that it gives people an understanding of the aspect of the injustices that occurred, but it also allows them to be able to look at the future of what they can be a part of. So if I was you, to go back to the aspect of your question about your particular coalition, I would take the position in terms of the aspect of equity. You know, that's what we're trying to achieve. And in terms of making sure that people are healthier about the way where we live, we all live here. So that is the position. We all live here. So we want to be healthier, but I would talk about how did it get that way, because that is the reality. And for those people who are new, so just like you said, the aspect of your population is changing. There are people who, they may seen it, you know, in terms of the aspect of walking around. They may have even read some books, but they probably don't really understand how did it get there. So that helps them to be a part of the aspect of the narrative, even though they really haven't been there all their lives.
Thank you.
I just wanted to say one last issue on this piece. So I call them focus groups, and I say that we were helping the community to understand what happened to them. But we also have to conduct what I tell my students are listening groups. We're listening to them. Because actually, of course, as always, the things that we thought would be so important to them were not. They want to be able to walk in their neighborhood. That was number one. They would like a grocery store because they are a food desert. And they want their kids to be safe. And then that's when the Daytona Beach Police Department joined the coalition as well. So just.
Thank you.
You know, can I add to that too? I think also with coalitions, most of us have community members, or we seek to listen to our community members, as you said. The other thing I would encourage us all to think about is skill building with our community members to give voice to that community from their own experience. The young woman that I talked about in the first case study, I actually was privileged to go to Washington with her. And we were talking with some very high-level government officials about the importance of maternal child health. And I'll tell you what, after about 5 minutes into that, she didn't need any of us. She carried that conversation. She had participated in programs that helped her build skills. And not only did she give voice in that meeting, she gathered her neighbors and they made a video to send as a thank you follow-up, telling their stories about what community programs in maternal child health meant to them. So I think sometimes having these activities gives voice to the people that we need to hear from.
Thank you. I got the sign that it's time to start wrapping up. I would just like to ask the panel to give us one pearl or two about how or what would they recommend to the audience as next steps in order to diversify their partnerships in their coalition. Just a pearl or two, because our time is limited. A closing statement.
Go home and think about how you can change the conversation. Think about what you bring that can help the non-traditional partners reach their goals, because that's also part of your message. We as coalitions need our non-traditional partners to engage with us, but they also need us to engage with them.
And quite similarly, think about how you can use a healthcare provider within your coalition, how they can help to frame some of the work that's being done, and particularly think about that postpartum care visit. I push it and I push it and I push it because it is a life changer for those women.
Really just 2 points in one. I said one already. Are you listening? Ask yourself, are you listening? And the second question is, have you done your homework? So, do you understand the social determinants? Have you at least perused unnatural causes and place matters? Have you, are you aware of the impact of the terms race versus ethnicity? You know, are you aware that biologically there is no such thing as race, right? So have you done your homework to be able to approach your communities?
So I just invite you to remember that dissemination and communication are key points of this particular project. So when you're thinking about the aspect of how you can disseminate and communicate about your project, really think about your community in terms of where do you want these messages to be? And I'm going to give you an example. For the aspect of if you're looking at a certain community and their socioeconomic status is one where they may not have computers in their home, but you know you need individuals to be able to talk to them through the aspect of online media, well, most of those particular organizations or individuals are going to go to libraries. Are you working with your local libraries? Now, they may not be someone that you're thinking about the aspect of being a part of your coalition, but they're a wonderful dissemination site. So that's what I want you to really think about in terms of the aspect of how you can get the message and the word out about the work that you're doing, and then look at your community partners from that particular standpoint.
Thank you. And with that, let's give our panel a round of applause. And just remember to think very broadly and try to diversify your coalitions in order to achieve health equity. Thank you.